So again, a very good morning, good afternoon or good evening from all around the world, I would say. Very welcome to this first I-PaRCS call, the International Partnership for Resilience in Cancer Systems, as we are newly rebranded. I want to welcome you all very much to this meeting. I realize that people are still dropping in, but I think we have a very full agenda, so I would like to start anyways. My name is Iris Lansdorp-Vogelaar, and I represent the International Cancer Screening Network within the I-PaRCS Consortium. And we're very pleased to see so many of you here for this first I-PaRCS call. If you would please enter your name and your affiliation in the chat so that we know who has been on this call. I want to briefly start with saying that we now are sort of past the worst of what seems to be COVID. And I think that was one of the reasons for our rethinking and rebranding the original CCGMC consortium, actually for two reasons. For one is that we realized that although COVID was over, or not over, but the worst has gone, we also realized that there are still many questions that we don't have answers to. So we felt that this consortium should really continue. And the other aspect was that this is a disrupting event, and more of these or other types of disrupting events could happen. And so it was very important that we have resilient cancer systems, and hence that's where the name came from. And also we realized that what we were doing here all together was much broader than just the modeling. So we felt that our umbrella term needed to be bigger, but you can hear much more about that, because one of the aims of today's calls is to review this consortium rebrand and the key highlights. And also again, and that's why we have a very full agenda, is to provide updates on all of the projects that we're working on. These are commissioned projects, including Cancer Research UK, the International Cancer Benchmarking Project, and World Health Organization systematic reviews, but also snapshots of the working group activities that have been active from the beginning. And then we want to end with a discussion of new opportunities and horizons for the consortium. If you have any questions for the speakers, please log your questions in the chat, so we hopefully can get to them at the end of the meeting. So I already started with the welcome and introduction. Then we're going to start with a wider perspective of COVID-19 and cancer, key consortium highlights and update, and then we are going to give an overview of the current commission projects, the other working group activities, and then finally the discussion of the new horizons and opportunities. And given that we are short on time, I would really like to get started with the meat of the meeting. And I would like to give the floor to Richard Sullivan and Julie Theroux to give a wide perspective of COVID-19 and cancer.
Iris, thank you very much indeed. Very good morning, afternoon, ladies and gentlemen. I'll get straight to the point and then hand over to Julie. So I speak to you really on behalf of the work I'm doing at the moment with the WHO pandemic preparedness, and also as chair of NATO's Global Health Security. Whilst I think there is a recognition that work needs to be done on creating more resilient preparedness in individual countries, nearly all of this has been focused, unfortunately, on infectious disease preparedness, in other words, for disease X. The discussions that are being had at the moment round with the Multilateral Development Bank and the major funders, interestingly, have received very little traction on the wider health systems effect. And I think that's been a really big issue in getting across to policymakers why this sort of work is important. And I think maybe, Karen, this is something you want to pick up a bit later on and then offline after this meeting, is that we're not making the progress we thought we would in trying to understand and build resilience into health services and systems per se, from thinking about this. Which makes, I think, the work of this particular consortium even more important, because there needs to be some advocacy movement with both WHO and the World Bank to try and persuade people that this sort of work is important and it is germane to building in future resilience. You'll all be aware within the clinical community, people have been moving on very, very quickly from the pandemic. we're going to do a wrap up of all the other pieces of work which we'll present at the next I-PaRCS around the world. People like the National Cancer Grid of India, etc., have been doing their own follow-up work, both in terms of health system services work, but also more broadly in trying to understand what sort of joint SOPs need to be put together for clinical informatics and biological sample collections within the context of pandemics. And those programs, I say, are happening at a kind of regional and national level. And again, something I can circulate, Karen, to the rest of the group. We've pulled all this together, what's going on. But just to say at the moment, this is extremely important, but the environment of getting this to the highest level and getting these sorts of things funded is actually quite difficult. Karen, back to you.
Thanks. It's actually back to Iris, but thank you so much, Richard. Agreed.
I don't know if Julie wants to add anything, or are we going to continue to the consortium highlights and updates?
Okay, perhaps it is back to me, sorry.
Yeah.
Okay. Thanks, everybody. So I'm just going to take a couple of minutes to take you through some of the highlights since we last met as a whole consortium, which has been a little while. And just very briefly, one of the, obviously one of the big platforms for showcasing our work was the World Cancer Congress in October 22 in Geneva. And we did, I think, have, as it was the opportunity, it was the moment where we rebranded ourselves as I-PaRCS. And we did have the opportunity to present some of our emerging results. And I think we did have a significant presence. So thank you so much to all that were involved in that. But essentially, we did co-lead a major session on COVID-19 impact on cancer services. And we also presented new work in 4 areas that are shown on the right here, which you'll hear about today, actually, is some of the emerging work that's now coming through into the publication space. And we also did the early what we call the beta launch of our new cervical cancer elimination planning tool, or EPT, which is one of the big projects that we've been working on as a consortium. This was originally designed as a tool to help countries in planning for recovery after COVID. It's kind of morphed in the general vein of becoming a partnership about resilience. It's morphed into being a much more generally applicable elimination planning tool, and you'll hear a little bit more about where we are with that as well later in this session. And we also, for that tool, have recently had some further beta test workshops. So that's been very exciting and good to see these outputs continuing to come, even as Richard said, in the context of perhaps some lesser interest and engagement in the wider impact of COVID on health services, as it is still indeed playing out, and we know that to be true. So moving on to the next slide. We just wanted to say a little word also about how we're seeing the consortium structure as we move forward into the new, I suppose, era of working around this more general vein of resilience. And so this diagram will be very familiar to you. As a consortium, we've always said we're about understanding all dimensions of cancer control, originally, of course, framed in the context of COVID, impact on cancer risk, impact on screening and early diagnosis, and impact on cancer care and outcomes. And we had originally conceived, as you know, of 3 working groups really focused on those 3 different areas. I think we've taken a little bit of stock and realised that, in fact, we've in effect worked to a much more mobile, living working group structure, which is quite project focused. So if we just move to the next slide, in practice, we've actually, for example, had working groups, very active working groups. We've got one called AusCan, which has been working on comparative COVID impacts in Australia and Canada. We've had the systematic review groups forming around specific projects in understanding the evidence and the synthesizing the evidence in COVID and cancer outcomes. And for example, in the prevention space, we of course have produced a major systematic review on COVID-related smoking changes. So I think, as it says at the top here, as we slowly transition, hopefully, out of the acute impacts of the pandemic, I-PaRCS will continue to work towards strengthening cancer control systems globally in consideration of both the current challenges as well as future health system challenges, whatever they may be, aiming to collect best evidence and consolidate information on best practices to provide tools and guidance for policy and decision makers. So really, we're really conceiving, I think, rather than these, this idea of these three major working groups, that we see that project teams will form on specific focused areas to produce outcomes, and then perhaps to move on with an update on that work, or perhaps to dissolve and form in a different way around another project. We do want to thank and acknowledge all the work that Richard Sullivan and Julie Terode have done, really to support us through the original COVID and Cancer Task Force, and re-emphasise to members here that I-PaRCS really has this incredibly expert resource, effectively, which was the task force, which you know we are able to draw on, I think, as needed and as required, and a huge amount of clinical expertise and expertise across different contexts, including in LMIC context as well, which I think, just to remind you, we're able to sort of to work with. So I think that's really how we're seeing the update at the moment, and our refocusing as I-PaRCS. So I think that may be the last slide I'm speaking to. So we'll move on now to give you specific updates around current commissioned projects, and I will hand over first of all to Harriet Hall from Cancer Research UK, who's going to introduce the update that we're about to give on the work that we're doing for the International Cancer Benchmarking Partnerships. Thanks so much, Harriet. Over to you.
Thank you, Karen. So first off, I just wanted to give everybody kind of a quick reminder of the context of the research. Next slide, please. So following the pandemic, ICBP wanted to undertake a transition phase focused on a few key elements. This included knowledge mobilisation, which was a review of all of our work since our inception in 2009. It was also creating formal networks to deep dive on the topics of cancer intelligence and data infrastructure, inequalities, lung cancer screening, and esophageal cancer research UK. So in addition to that work, we realised that we were in a very unique position to understand the impact of COVID-19 on cancer services. And we were hoping that this work, combined with our other activities, will heavily feed into phase 3 and our next bit of research, which will begin later this year. Next slide, please. So we decided to commission 2 pieces of work to really build a picture and understanding of what was happening in our ICBP jurisdictions. The first piece we commissioned was through IARC, who also conducted our phase 2 benchmark, and it was for them to quantify the impact of COVID-19 on cancer outcomes through statistical analysis, in particular looking at incidence, 1-year survival, and where possible an available stage. We decided to focus on a few key cancer sites with different routes to diagnosis, just to give us a good picture. We partnered this research with the Daffodil Centre's mixed methods approach, and this is really to understand the context by collating and exploring the impact of COVID-19 on health system and clinical policy. And again, we limited the cancer sites to provide a bit of a deep dive. We hope by bringing these 2 pieces of work together, we will have a greater understanding of what happened during the period and a better understanding of what mitigation strategies were involved, as well as pulling all this together to greatly benefit our next phase of research. So thank you very much. I'll now pass over to Karen and the team to present on what they've done so far.
Thanks, Harriet. Hi, everyone. My name is Karen Chiam, and I'm a research fellow at the Daffodil Centre. And today I'll be presenting an overview on one of the ICBP projects on behalf of our team. Next slide, please. So for today's talk, I'll be focusing on the Mixed Methods project. I'm not going to go over the aims that Harriet has kindly already go through. But for this Mixed Methods project, we have undertaken 2 different approaches to address our aim. So the data is collected through both a desktop review of rare literature materials and also through qualitative surveys and interviews with the ICBP stakeholders. And we have also conducted stakeholders interviews on 3 specific case study topics, which are described in the bottom box here. And this is to allow us to explore and have a deeper insight on the impact of the pandemic on specific cancer service or cancer type, which can then be used to inform and provide learnings for all the jurisdictions. So this case study and exemplar jurisdictions are selected based on 5 selection criteria, including the considerations of the lockdown stringency of the selected jurisdictions and the complementarity with the IARC quantitative project. Next slide, please. So another important component of this project is the mapping and comparison of the COVID-19 lockdown stringency for the ICBP nations. And this is done using the Oxford Stringency Index, which is a numerical value calculated based on several lockdown measures for each jurisdiction. So a high stringency index indicates a strict lockdown period and is represented by the yellow color in this heat map, whereas the dark blue color indicates a more relaxed restriction period. So the take-home message here is there are variations in the lockdown stringency across time and jurisdictions, and this is an important consideration during the interpretation of our study findings. So next slide, please. So in the interest of time today, I have selected some interim findings from our desktop review activities to demonstrate the kind of information we are interested in. Next slide. So one of the key outputs for this project is to identify and map the key disruptions of specific cancer service, such as the cancer screening programs. So the graphs that you are seeing here show the temporary suspension of breast, cervical, and colorectal cancer screening programs in the ICBP participating nations in 2020. So the period and duration of the disruption varies by program and across the jurisdictions, but most of the suspension occur only in the first year of the pandemic. New Zealand is the only ICBP nation that also experienced a short period of suspension in their breast and cervical cancer screening in 2021. And also to quickly note here that the graphs are showing an overall representation at the national level and do not reflect any differences in the disruptions that may occur at the state or regional level within a country. So next slide, please. Another key output for the project is to consolidate the recovery and mitigation strategies for each jurisdiction. And in the case of cancer screening, most jurisdictions have undertaken similar actions to minimize the impact and catch up on the backlogs of screening. And this includes the implementation of COVID-19 safe protocol measures, using telehealth consultations, prioritizing their catch-up services to high-risk individuals first, and coming up with campaigns to promote the safe returning of cancer screening. And for breast cancer screening, some jurisdictions have adopted mobile screening services to increase screening activities and catch up during the pandemic. Next slide, please. So unlike cancer screening, the disruptions in cancer treatments are found to be more haphazard and recurring. And as an example, in the UK jurisdictions, we identified reports on the temporary suspensions of non-urgent chemotherapy and surgery for at least 3 months in the initial wave of the pandemic. Next slide, please. So overall, surgery is identified as the most impacted cancer treatment type during the pandemic in the UK. And this table here is an example that summarizes the events of the disrupted elective surgery procedures identified in each of the UK jurisdictions. And this really demonstrates the recurring disruptions that is still affecting some of these jurisdictions up to late 2022 and early 2023. Next slide, please. So the recovery actions and mitigation strategies for cancer treatment are more complex and varies by treatment type. But overall, there is a change in the treatment options offered to cancer patients. For instance, by offering safer alternative options to patients who are immunocompromised or are unable to receive a planned surgery. There is also a change in treatment regimens, such as the increased uptake and recommendations to switch to hypofractionated radiotherapy and oral chemotherapy in order to reduce the number of hospital visits required by the patients. In the UK, guidelines on how to prioritize cancer patients for each cancer treatment types are also developed to assist the clinical decisions and treatment planning of cancer patients, especially during a time where resources and service delivery may be restrained. And in the UK, another early response to the pandemic is the setup of the temporary hospitals and hubs, such as the cancer and surgical hubs, to provide ongoing treatment services to cancer patients. Next slide, please. So in summary, the grey literature information that we have collected so far are quite extensive, and we are currently working on developing the grey literature reports for each of the ICBP participating nations. The data collection for the survey and interviews are also completed, and we are at the stage of doing analysis for this component, which will result in a separate collective report for the ICBP jurisdictions. So the overall key findings of this project will be used to inform and develop key recommendations for the ICBP jurisdiction and assist the interpretations of the findings for the quantitative I-PaRCS project. For instance, by providing some insights and justifications to any observed impact of COVID-19 on cancer incidence and mortality in a particular jurisdiction or cancer type. So this project is planned for completion at the end of June 2023 this year, and hopefully we'll be able to share more of our findings at the next consortium meeting. Thank you. And next, I would like to pass this on to Ms. Elle Pearson from the Cancer Research UK.
Thank you, Karen. Good morning, good afternoon, and good evening, everyone. I'm Elle Pearson, and I lead on Cancer Research UK's global policy work on HPV vaccination. And I wanted to share a bit of an overview about the elimination planning tool, which we've been supporting with the Daffodil Centre. Although I know some of you will already be very familiar with this work, but in way of a bit of background. So in September 2021, we at Cancer Research UK agreed to support Karen and her team, which included Isabel and Morton at IPaRCS, in developing a tool that could be used by policymakers and advocates to better understand and mitigate the impact of COVID-19 on global cervical cancer elimination. This aligned with our goals as Cancer Research UK because since around 2019, we've been working to support researchers and organisations committed to driving policy change and improving equitable access to the HPV vaccine for girls in low and middle income countries, specifically with the aim of preventing cervical cancer. So when this project was originally launched, the expectation was that it would be focused on the impact of the pandemic and the gains that different interventions such as catch-up programs and gender-neutral vaccination could make in getting elimination efforts back on track. But as Iris and Karen spoke about at the start of the call, our relationship with the pandemic evolved and the project evolved, and the Daffodil Centre team recognised the importance of capturing slightly wider delays to elimination beyond COVID-19 and how these different pillars and the different interventions can demonstrate resilience and interact with each other, ultimately to change a country's trajectory towards elimination. And so these different elements were built into the tool as well. And crucially, the team also included within the tool a readout of the resources that would be required to achieve this progress towards elimination, as well as the return on investment gained from it. So the outcome of all this work is the Cervical Cancer Elimination Planning Tool, which is a brilliant data visualization tool and accompanying briefings that will sit on IPaRCS Global Cancer Observatory platform, and it will be freely accessible to anyone who wants to use it. And our aim is that the tool and the briefings will be used by civil society and policymakers to inform their national approach to cervical cancer and really support countries in effectively planning their path towards elimination. So as Karen mentioned, we've been through a beta testing phase and the tool's now been finalised following completion of this. And this was a really great additional phase that we included into the project to gather a wealth of insight from civil society, as well as the WHO on how the tool could be improved to ensure it's as accessible as possible for its users. So I think I'm handing over to Michael after this to let him go into the details of the tool and its new capabilities since you saw it last. But I'm sure for those of you who haven't seen the tool in its most recent iteration, you'll agree it's a fantastic resource, and it's been such a pleasure to work with the Daffodil and IPaRCS teams within its development. So thank you. And as I said, I think I'm handing over to Michael.
Thanks, Elle. It'll actually be me for this first session. So Hi everyone, my name's Adam and I'm a research fellow in Karen's team at the Daffodil Centre. So yeah, I'm going to talk a little bit more about the elimination planning tool. So next slide, please. So yeah, just acknowledging the huge team effort here from those in the Daffodil Centre, Isabel and IPaRCS and CRUK and Julie Tarot at King's College. So next slide, please. So the goal here was to give policymakers and researchers a tool to look at different scenarios for their country or region of interest in a straightforward way, and to be able to look at, for them to be able to look at the different goals for the pillars that might be achievable in the long and the short term. And so the user interface was developed by IPaRCS in consultation with the group on how it might look, sort of following a style a bit like the Global Cancer Observatory, and with the underlying data coming out of Daffodil Centre's Policy One Cervix platform, which has been applied over a fairly long period of time now for a range of different settings and situations. And so the main inputs are the different coverages of the three pillars over time, and users would also have the opportunity to choose different accelerators, such as, for example, multi-age catch-up, extended multi-age catch-up for vaccination. And we can potentially envisage later versions adding more features and scenarios as time goes by. And so outputs include impacts such as deaths averted, versus status quo, elimination year, resource use, and various economic indicators. So yeah, next slide, please. So this is just a snapshot of an early version of the live tool that was presented at the beta testing sessions by IPaRCS. And in the left margin, we have basically the model inputs, and on the right are the outputs. So for the inputs, we can see the population at the top to select. It's blurred here, but one could select a given country or region or income level and compare them. And then we can see lower down the various choices about pillar targets over different times. A user could click on, say, intermediate targets and select their coverage and year, the drop down. So I can see at the moment, for this one, it's the 90-70-90 elimination target that's selected there. And then with the outputs, we can see some of those key indicators. So at the top, the elimination year it could give for a country, some of the economic indicators like return on investment, budget impact, and then we got some key graphics there, such as the ASR incidence over time. And there's a little annotation, you probably can't see that it's pointing towards the year of elimination there, if it's reached. And then the graph on the right is showing the cumulative lives saved over time compared to status quo. So next slide, please. And so in the above interface, there'd be options for users to download tables and so forth as CSV files. But as well as that, there'll also be a tool to be able to generate a PDF for each country that summarizes some of those key modeled scenarios in maybe a 2 or 4 page report, and synthesizes it with other data specific to that country, and positioning these in relation to the WHO elimination strategy. So you can see those 3 pillars color-coded there. And this would follow like a standard template that fills in the blanks in terms of the numbers for a given country. So just to sum up, there was a lot of positive feedback and excitement from the beta testing workshops on this, and they were well attended. And I think people were happy about the utility and the ease for this, but there was also a lot of suggestions for different features that could be included that we'll be looking at. So I think I'll hand over now to the next person. Thanks.
Thanks, Adam. And then we will have Julia Steinberg talk on the systematic reviews.
Thank you very much. I'm delighted to be here and to present our work on COVID-19 and cancer systematic reviews commissioned by the WHO. Based on our previous research and discussions with Andre and Felipe at the WHO, the 3 topics shown here were prioritized for systematic review. I will tell you about our work on the risk of COVID-19 related death for people with cancer, and then I'll hand over to Richo, who has been leading the work on determining the impact of the COVID-19 pandemic on delays and disruptions in cancer care and the mitigation strategies that were adopted to reduce these delays and disruptions. I want to highlight that all 3 reviews were very much collaborative efforts that were only possible through fantastic teamwork within IPaRCS, and so we would like to acknowledge the great contributions from the international team shown on this slide. Thank you. As the name suggests, our review aimed to assess whether people with cancer have a higher risk of COVID-19 related death than people without cancer. And we considered studies of the general population as well as separately studies of individuals who have been diagnosed with COVID-19. Building on our previous review of the early literature on this topic, here we aim to specifically synthesize higher quality studies carried out in the pre-COVID-19 vaccination period. That means we wanted to focus on estimates that considered the time since cancer diagnosis or treatment, so they did not jointly consider long-term cancer survivors with those recently diagnosed. And we also wanted to focus on estimates that have been adjusted for at least age and sex, but were possible also for other important covariates, such as the presence of other health conditions. We searched the WHO COVID-19 database at the end of December 2021 using keywords related to COVID-19, death and cancer. This search yielded over 17,000 title abstract records, really showing that the collaborative effort within I-PaRCS was crucial to making this review possible. From this immense number of search records, we identified 23 studies that satisfied the inclusion criteria and could be included in a quantitative synthesis of the risks. We synthesized risk estimates separately for different combinations of population, cancer type, and measure of effect, so odds ratio or hazard ratio in this case. As shown on this slide, this gave us a total of 21 different risk estimates consolidated in the review. In red we show the estimates for all or solid cancers together. Here the evidence suggests an elevated risk of COVID-19 related death for people diagnosed with recent cancers, with adjusted odds ratio, adjusted hazard ratio estimates around 1.3 to 1.7. And I should note that these analyses include risk estimates for the most recent time since cancer diagnosis or treatment provided in a study. So, for example, if a particular study reported risk estimates for people up to 1 year post-cancer diagnosis, as well as for those between 1 and 5 years after cancer diagnosis and over 5 years since cancer diagnosis, then in the analysis here we included the risk estimates specifically for people within 1 year of cancer diagnosis. But I will tell you more about time since cancer diagnosis or treatment in the following. We also consolidated risk estimates for specific cancer types where available. As shown here, we found elevated risks for people diagnosed with lung cancer and also for those diagnosed with hematological cancers. There were only 2 studies that reported separately on other cancer types, and from those we found elevated risk specifically for those diagnosed most recently with prostate, breast or colorectal cancers. Finally, we also found an elevated risk of COVID-19 related death for those diagnosed with metastatic cancers compared to those without. As mentioned, one aspect we're particularly interested in is how the risk of COVID-19 related death changes by time since cancer diagnosis or treatment. So we carried out a meta-regression to assess this. The results for any or solid cancers are shown in the figure here, separately for analysis based on hazard ratios and on odds ratios. Across both, we found a marked decline in reported risk of COVID-19 related death with longer time since cancer diagnosis or treatment, as illustrated by the red dashed lines. This analysis also allows us to calculate predicted estimates for specific periods after cancer diagnosis or treatment. For example, across all cancers together, the fitted odds ratio estimate is 1.7 at 1 year and 1.2 at 5 years after cancer diagnosis or treatment. We can also use the meta-regression to try estimate very roughly when the risk of COVID-19 related death for people with cancer might again become similar to the risk for people without cancer. There are a lot of caveats to this aspect due to how the uncertainty is captured in the meta-regression. But very roughly, in the analysis of all cancers together, the 95% confidence interval for risk estimates includes one from about 4.4 years after cancer diagnosis or treatment. This generates a hypothesis for future studies examining in more detail how long elevated risk of COVID-19 related death might persist for people with cancer, and how this might also depend on cancer type and COVID-19 vaccination, as well as other key factors. In conclusion, our review found that in the pre-COVID-19 vaccination period, the risk of COVID-19 related death was higher for people with recent cancers, with variation in risk depending on cancer type and the time since cancer diagnosis or treatment. We want to highlight that more research would be needed to determine how these risks depend on key factors such as age, sex, aspects of cancer such as cancer type, stage, or time since cancer diagnosis, as well as the cancer treatment that was received and the time since cancer treatment, but also important aspects of COVID-19 virus variant, as well as COVID-19 vaccination and treatment. This means that robust and in-depth analysis of population-wide studies linking cancer records and, going forward, COVID-19 immunization records remain very important to accurately estimate the risks and to inform the ongoing public health response and build resilience to the COVID-19 pandemic going forward. In addition to that, living systematic reviews are important to provide an up-to-date consolidation of high-quality evidence, including a critical evaluation of studies. This would be important to accurately estimate the impact of the COVID-19 pandemic and evaluate mitigation strategies that have been adopted, but it will also be important to build infrastructure for future emergencies. Thank you very much for your attention.
And now over to Dr. Richa Shah from IPaRCS.
Thank you very much. Can you hear me? Yeah, thanks.
Yes,
Hello.
we can.
Yeah, hello everyone. I'm Richa Shah. I'm from IPaRCS. I'm a postdoctoral fellow there. I'll be presenting about the other two reviews that we are conducting at the moment. So for this, for the other two reviews, we performed a database search in WHO COVID-19 database from the 1st of January 2020 to 17th April 2022. And we are performing two studies. The first one is a systematic review and meta-analysis, which looks at the potential impact of the delays and disruptions caused by COVID on patients who were screened, diagnosed, or treated for cancer. And the second one is a scoping review, which is titled Global Review of Mitigation Strategies and Their Impact to Reduce Cancer Service Disruptions During the COVID-19 Pandemic. So I'll be focusing on the first review, which is a systematic review. So as you can see on the Prisma diagram towards the right of the screen, our search identified more than 9,000 articles. And from these articles, we eventually included 246 studies for the first review, which is a quantitative synthesis of service disruptions. And we included 30 studies in the scoping review, which is a qualitative assessment of mitigation strategies. Next slide, please. So we'll be talking about three outcomes, which are diagnosis, screening, and treatment, and briefly about diagnostic procedures. So as you can see in the screen, we included about 1.6 million cases for the diagnosis outcome, and overall there was a decrease of 24% of cancer diagnosis during the pandemic period compared to the pre-pandemic period, and the highest decrease was seen for hematological cancers in the body systems. And this was followed by gynecological cancers with a decrease of 35%, and skin cancers with a decrease of 33%. And also you can see that lung cancer's diagnosis decreased by 15%. And for diagnostic procedures such as CT scans, biopsies, they decreased by 38% during the pandemic period compared to the pre-pandemic period. And for screening, we had about 60 million cases. And as you can see, the breast cancer screening decreased by 49%, colorectal cancers by 21%, and cervical cancers by 39%. As for treatment, the overall treatments during the pandemic period decreased by 27%, and the treatment decrease was much higher for medium HDI countries, compared to the very high HDI countries. But it should be noted that in this study, we did not have any studies from low HDI countries. And overall, we had 48 countries included in these two studies. So that's a very brief presentation from my side. I would like to hand over to Professor Iris.
Thank you so much, Rika, for this overview, and also Julia for the overview. Very interesting. I just wanted to make a point to Harriet and Karen that there is a question in the chat, because I don't think we will have time to go to that in the end. So if you could please answer that in the chat. Then we're going to very briefly go over to snapshots really of what's going on in the cancer screening working groups. And the first one would be Pietro Procopio to present on the breast team.
Hi everyone, Pietro Procopio from the Daffodil Center here. I'll give you the update on behalf of the breast cancer screening WC2 group. And next slide, please, thanks. So the rapid review paper on COVID-19, on global impact of COVID-19 on breast cancer screening, were led by Janine Figueroa group, can be found on the medical archive now. Sorry, on the medical archive. And it encompasses some finding for what concern a reduction in screening and uptake, and found some sensible disparities in the US context. We recently started a comparative study between Australia and Denmark, and this will focus on breast cancer incidence, especially on population level and screen detected cancers and CCGMC. Then, we also focus on screening program performance indicators, characteristics of the population and characteristics of the tumors. And at the moment, we are waiting for further data from the Statistic Denmark to progress the analysis further. And lastly, we are changing the focus on the modeling study of COVID-19 impact on selected regions in Italy, and focusing now on the impact on population of delayed diagnosis and treatment. I just wanted to mention that once the comparative study is between Australia and Denmark is finished, we refine the methods. We are very happy to expand the study to multiple countries, to additional countries. So please get in touch with the Secretariat or with us directly if you are interested. Thank you very much, and sorry for the noises. Oh, sorry, there was the slide. Sorry, I don't know what happened here. Yeah, so well, anyway, yeah, those are in practice the same things that I said. I thought that those slides were in place of the first one. Sorry, anyway.
No problem. Thank you so much, Pietro. Then we go on to Megan for cervical cancer.
Thank you very much, Iris. Next slide. Thank you very much. So we just had a quick update on 3 publication activities. Firstly, we were invited to submit a commentary article to a special issue of HPV World. The issue was titled "The Role of Modelling in Informing Policy and Planning for Prevention and Control of HPV-Related Cancers." And the article, which I co-authored along with Emily Berger and Inge de Kock, summarises the I-PaRCS the work related to cervical screening modelling during the pandemic in high-income countries, and it was published in late March this year. Secondly, we undertook some new modelling to evaluate how temporary disruptions to primary cervical screening services might differentially impact women as a result of heterogeneity in their screening history, and also the type of screening test that they'd last been screened with. And the 3 independent models predicted that the main drivers of cervical cancer risk were screening frequency and screening modality. And so that means the type of test. And so the overall impact of disruptions from the pandemic on cervical cancer might be small, but screening disruptions are disproportionately going to affect people who are underscreened. So a very consistent message that the importance of focusing on these women, regardless of temporary disruptions to screening programs, it's critical that we reach the most underscreened women. And thirdly, Sharon Hanley is leading a manuscript by our group, which is focusing on summarising key indicators of screening program status in every high-income country directly prior to COVID disruptions. That's going to inform some future modelling work, and that manuscript's currently in draft. That's all. Thank you very much, Iris.
Thank you, Megan. And then up to Francine, it says here on the update for the colorectal cancer screening team.
Hi, everyone. My name is Francine, and I'm from the Amsterdam UMC in the Netherlands. And previous projects in this working group has assessed the possible impact of hypothetical COVID-19 related disruptions and how to mitigate using limited colonoscopy resources. And in this project, we has completed an extensive study on the global impact of colorectal cancer screening decreases related to COVID-19. And we also generated model-based estimates of the long-term cancer burden caused by these decreases. Next slide, please. The analysis was performed by 4 modeling groups, and we included 30 countries for which we observed decreases to screening based on available data, or we estimated this decrease based on COVID mortality data when the data was not available. And using the observed and estimated decreases to screening, we estimated the global impact and the benefit of providing catch-up. To do so, it was not feasible to simulate all those 30 countries in the screening program. So we made 5 different categories differing in the test, the age range, and the interval. And we simulated only a set of participation rates for each program category. And then we assigned each country screening program to one of those categories. And we derived the outcomes for each country at the country-specific participation rate by interpolating between the simulated participation rates for each category. And in the next slide, you can see the estimates of the global impact on the cancer incidence and mortality over the next 3 decades due to the decrease in screening in 2020. And it was predicted that globally, these disruptions lead to over 16,000 additional cases, the blue line on the left, and over and nearly 10,000 additional deaths, the blue line on the right. And by providing catch-up screening for those that missed screening in 2020, the orange lines, these increases can be reduced by 80%. Next slide. To conclude, this work shows that a temporary decrease in screening will significantly impact cancer burden or colorectal cancer burden over the next 3 decades. And when real-world data of a country becomes available, the results of the study can easily be used to derive estimates for that country. Catch-up screening should be encouraged if health resources can be allocated. And the manuscript is currently under review, and the work will be presented at the biannual European Conference of the Society for Medical Decision Making. Thank you for listening.
Thank you so much. And then Joachim, it's up to you to go on to the OSCON comparison.
Thanks, Iris. So I'll just be briefly presenting on the OSCAN work. This is a collaboration on colorectal cancer between myself and our collaborators in Canada, particularly Julie Sun and Talia Mulligan. So the aim is to consolidate some data on delays to diagnosis, treatment, and the screening work that Francine's just mentioned, and calculate the overall impact on both cancer services and projections of cancer incidence and death. So on the next slide is a brief overview of the methods, which I'll just go through quickly. So a decrease in procedures, for instance, diagnostic procedures like colonoscopy, can create a backlog, right? Even if there is efforts to reduce that backlog and bring people back into diagnostic procedures, that waiting time until they receive their procedure can lead to worse outcomes. So for instance, this additional waiting time to diagnosis, and if we click through, can lead to a hazard ratio from, for instance, in this case, Hannah et al., of a 4-week delay leading to worse outcomes in terms of overall survival. So we use these methods to apply to both Australia and Canada population, and on the next slide we can see the overall outcomes. So in the range of about 250 cases and deaths, 250 cases in both Canada and Australia. and 1,800 deaths in Canada and 1,200 deaths in Australia, attributable to the overall impact of screening in screening, diagnosis, and treatment. So primarily these are due to diagnostic and treatment delays, but over a longer timescale, there'll be more due to screening disruptions due to the long tail of the impact of screening. One of the things we learned on the theme of robust health systems is that even a small increase to capacity to either treatment or diagnostic procedures would avert many of these additional deaths. So even a 5% increase to treatment capacity would avert the worst of this. And now I'm handing back. Thanks, guys.
Thanks, Joanne. Then, Karen, it's up to you to talk about the exciting new collaborative projects.
Thank you very much, Iris. Well, I'm just going to take a couple of minutes at the end to tell you about some thinking that we have been putting together, I suppose, a new project plan, really thinking about a more data-driven look back to actually what do we know and what don't we know about COVID-19 disruptions and their impact on cancer. And in doing this, I think you've heard a lot today. You've heard about the important work for the ICBP, which will really collate stakeholder insights and also data on cancer registrations for ICBP jurisdictions. You've heard about some of the modelling, and you know that some of the early modelling that we did as what was then the CCGMC and now I-PaRCS was really quite constrained because it really had to use hypothetical scenarios for delays and recoveries because we simply didn't have good data on what actually happened in health services at the right level of granularity. And you've heard even now when we're looking at the global impact, for example, of colorectal cancer screening disruptions, about the need to make assumptions about the extent of those disruptions in many countries. And I suppose what we have experienced is, if we reflect back on the last few years, is that there has been, I suppose, that over time, as we start to look back in hopefully a little more in the rearview mirror, more and more data does emerge at a national level. And here we're talking about emerging country data on the impact of the pandemic on health services, exactly what happened in terms of procedures and their delivery and delays in delivery and diagnosis and in treatments, exactly what happened in screening programs, as you've heard about. And of course, more and more we're seeing the emergence of actual data on cancer registrations and the important work that IARC are doing for ICBP. But beyond the ICBP jurisdictions, of course, more and more information is emerging. We're also interested in very much putting this together with the picture around excess deaths due to cancer. What are countries experiencing in terms of actual excess deaths? How is this playing out with competing risk due to other comorbid conditions in cancer patients that may have also been impacted by the crisis? How does the thorny issue of registrations and how COVID-19 deaths were handled in the registration systems play out in terms of what we see in cancer registrations and cancer deaths? And also, how does this actually fit together with what we are hearing and again, as more data emerge about the actual experiences that screening participants had, that patients and carers have experienced through cancer care and services. So if you like, this is an attempt, this project will be an attempt to look back with the review, hindsight over the last 3 or so years, to really use what's available in the data and to try and form a bit of a consolidated picture on what is known, what is actually known now about the impact, and where do we still have areas of uncertainty. Our plan is to initially to keep this simple because we think this will be a multi-country exploration, and really we're looking for expressions of interest of those that may be able to come in from countries to connect with the data that's emerging. But we're really looking initially to start with lung and colorectal cancer, which have been, I suppose, chosen as examples of high burden cancers where in one case, of course, there's in many countries established screening in lung emergent screening approaches, but where there is, of course, a very different baseline survival overall, and where we expect that it's at least potentially possible that the impact of the pandemic on actual outcomes in lung and colorectal cancer patients may be nuanced and differentiated. So we're really looking, we formed a small working group from interested investigators, building on the AusCan work that you heard about earlier, but from Australia, the Netherlands and Canada. But we're really interested to incorporate those from other countries. And again, just to emphasize, this is not intended to repeat any of the work that you've heard about today. It's actually intended to build upon it as we move forward over the next period, where again we're seeing that important emergent data about what's actually happened over 2020 and 2021, and with the hope of consolidating it. So if you are interested, the email is there for the Secretariat, and we really would be delighted if you would like to join us. So with that, thank you. I will hand back to Iris to wrap up the session. Thanks, Iris.
Thank you so much, Karen, and thank you so much to all the speakers who presented all of these exciting and all of this great work that's going on. And we also realized that many of you have been contributing to this work pro bono, and we really acknowledge, I want to thank you for that. And then we also felt that it would be good if you could have something to show your participation in this consortium. So for those of you who are interested, we have developed a certificate of participation in this I-PaRCS and formerly CCGMC consortium. And if you want to have such a certificate, please reach out to the Secretariat. The email is at the bottom here, and we can arrange one. It will be tailored towards the contribution that you've made, so that you can really showcase the important work and participation you have done in this consortium. So we really appreciate all of you who have done that so far. On the horizon, well, actually, we will be aiming to hold the next Fall of Consortium update around September or October of this year. So we hope that many of you will be there then too. We will have another session of the same call this, for me, evening, for other people, other parts of the day. So if you can get enough, feel free to join again, but it will be the same as what you've heard this morning or this evening or afternoon. And again, Karen already stressed it, but we would like to invite you, if you are interested. For example, we heard the invitation to join the breastwork between Denmark and Australia. If you think, well, we have data and we would love to contribute to this project. Same for lung and colorectal, for what Karen was presenting, or one of the systematic reviews. We don't have to, it's not just modeling. I think that's very clear from today's presentation. So if you are interested and you think you can contribute to any of the current projects, please reach out and we would be happy to include you in that. I think that was all there was to say. Yes, other than thanking you very much for your contribution, for your presence today, and all of the presenters for their excellent work. And we're really looking forward to continuing this exciting consortium. And as Karen said, we're now just starting to see the impacts on in real data. So there are still a lot of things that we can do, and still a lot of lessons that we can learn. So we're definitely alive and kicking and want to go on. There was one question in the chat about the availability of the slides. If I'm not mistaken, the slides in PDF form will be placed on the I-PaRCS website. I see Karen nodding, so thank you all very much for that. And I wish you a pleasant day, evening, night, and hope to see you again next time.